this is there is still some feeders from the left PCA that to the deep venous system. There is some supply still present. Anteriorly, it's almost been occluded. I'll call Rajiv Sharma sir.
Professor Salesh sir has done the emulation. So may I request Professor Salesh sir to put his comments about what has been done yesterday?
As discussed, there was supply from the antecerebral artery, which was more like a fistulous component. So selectively going to the pericallosal, I knocked off this fistula by depositing the onyx. Onyx keeps little more delivery time so that progressively you can occlude large part of the AVM fistula, as well as if there is any nidus, you can then deliberately penetrate that. Then we went through the posterior cerebral artery also. There was a large feeder which was more like a nidus type. So for almost 20 minutes, onyx was injected and we occluded the superior and the anteriormost part of the occipital lobe AVM. Then we went to the MCA. MCA has a very large and tortuous course. My understanding was initially that probably it's in the watershed zone, and it may not be a direct feeder, it may be a kind of a angiogenetic response. But when I went in selectively with the microcatheter, I found there was a large fistula. So there was no choice but to occlude that fistula and leaving behind the rest of the AVM so that I think the neurosurgeon can operate on the residual AVM. But yeah, still there is possibility we can go in again. So this was the case, and it had 2 sessions. The first time the material was not ready, then we provided some material from our department. Next day the material arrived and we went in for the second time. So most of the part of the EVM is gone, but there is still a residual, I think, and Tanikawa is the best judge whether to go in for surgical resection or whatever is planned. I think most welcome.
Thank you, sir. Thank you, sir, for your comments. May I request Professor Tanikawa to discuss the plan of today's surgery? Image खोलो. Sir, perimetry has been done. Vision is normal, and after ambulation, it was done late in the night. So we'll check it morning. It was done late in the night yesterday. Yes, sir. Pre-ambulation we had checked, it was normal. Even perimetry was done, that was normal. Post-ambulation we have not checked. I will check it before taking the patient. Yes, sir. Just reaching. Yes, sir. Yes, I agree, sir. May I request Professor Tanikawa to kindly put his comments for the regarding today's surgery planning and discussion.
Yeah. Before embolization, of course, before surgery, the patient visual field, visual acuity is almost normal. But unfortunately, the nidus location is completely eloquent in character area. So if we try to remove this AVM, the optic radiation must be injured, and the optic center will be injured. So to avoid the hemianopsia is maybe.
Yeah, we have informed the patient regarding the possibility of vision related issues post-operatively. Consent has been taken for this.
Yeah. So today it's working. Yeah. Today we will make the position of the patient in the left side down with the park bench position. and the patient head should be rotated to the downward, and we can, of course, with this positioning, the left hemisphere can be pulled by the gravity from the falco tentorial, and we can. It makes it easier to approach to posterior interface fissure. But the main part of the surrounding, the brain tissue surrounding AVM has already damaged by the previous breathing. So relatively, it's easier to dissect the nidus to dig the brain tissue along the AVM nidus. But currently, almost the ACA is occluded, and the PCA is still remaining. So the key is to secure the PCA just proximal to the AVM nidus. And the draining system, especially in this case, the drainer is coming to the deep venous system, almost connecting to the vein of Guerin, the straight sinus, and the venous reflux is coming normally to the internal cerebral veins before embolization. But the perfusion pressure is very much reduced. So if we carefully dissect the nidus, preserving the deep draining system, finally we can remove the nidus safely.
Thank you, sir. Thank you for comments. Any questions for Professor Tanikawa? Audience, any questions? Dr. Shweta, would you like to put any comment regarding possibility of radiosurgery now?
It is a good size nidus now for surgery also, but definitely surgery remains the first choice. But I think it is amenable to gamma knife radiosurgery as well.
Thank you. This patient had a bleed in 2015. After that, he was lost to follow-up. He is a laborer working in Patiala. Very likely to get mixed up again after we discharge him without surgery. That's why the decision of surgery was taken compared to gamma knife. Thank you.
So the main part of the EVM is in the parietal lobe. It's not in the occipital lobe.
Yes. Thank you, sir.
Priya, can you show cases, the cases for the other operation rooms as well? First showcase for Professor Suri. Current आ रहा है? No, it's not static current. It's current. यहाँ पे current आ रहा है. इसमें देखो, इस पे हाथ में. मेरे को तो लगता है.
कनेक्ट होगा. इसको उधर रख लो फिर यहाँ. कैसे? अभी ट्रांसफर मत करना. आए ट्रांसलेशन
ये वाला अपना वाला ले गया, ये वाला ना अपना वाला ले गया, सी वाला अपना ले गया।
नहीं आ रहा पेन ड्राइव इसमें ये कनेक्टेड है ना,
हाँ ये
इसमें पेन ड्राइव में डाल देते हैं लोग। इसी में डाल रही हूँ मैं, ठीक है। अरे निकाल दिया उसने बिना पूछे, ऐसे नहीं निकालना है इसमें से। पता नहीं
स्विच कर लो। इससे ले नहीं रहा।
So this is the case in OT1. So she's a 53-year-old female. She is being operated by Professor Suri. She presented to us with holocranial headache for last 2 years and left-sided hearing loss for last 1 year. And along with that, she also had complaints of imbalance while walking for the last 6 months. On examination, her vision on right side visual acuity was 6/12, left side visual acuity was 6/36, and on examination of the fundus there was grade 3 papilledema. Cranial nerve 5 examination only, there was left side direct corneal reflex was impaired, the sensation was normal. 7th nerve was intact. 8th nerve examination was suggestive of left side sensory neural hearing loss. Gag was impaired on the left side and uvula was central. Power was 5/5 on bilateral upper limb and lower limbs, and cerebellar signs were present on the left side. PTA was done and it showed left side profound sensory neural hearing loss and right side mild hearing loss. This is the T2 imaging, T2 axial imaging, which shows a heterogeneously hypointense lesion in the left CP angle, extending into the left internal auditory canal with widening of the internal auditory canal, with upstream hydrocephalus due to mass effect on the fourth ventricle and the brainstem. The coronal T2 imaging of the same patient. The sagittal imaging. This is the T1 contrast imaging, which shows heterogeneously contrast enhancing lesion. The coronal section of the same. This is the bone window of the NCCT head. Yes. So we'll discuss the rest of the case later. Now we'll move on to this Sarveshwari oration.
A very good morning to all of you and welcome to AIIMS New Delhi. On behalf of the Institute, it is my privilege to welcome you all for the 34th edition of the Sarveshwari Memorial Oration on Neurosurgery. So to begin with the proceedings, I request our Director Professor M. Srinivas to welcome the orator with a bouquet. So to carry forward with the proceedings, I now request Professor S.S. Kale, the head of the department Neurosurgery, to introduce the oration and also the orator.
Thank you, Dr. Girija. Professor Srinivas, Director AIIMS, Professor Verma, Dean AIIMS, Dr. Girija, Registrar AIIMS. I can see the Associate Dean, Dr. Rajiv Kumar also here. All other officials of AIIMS, seniors, my teachers, colleagues, residents, fellows, guests from overseas, ladies and gentlemen. I welcome you all to this 34th Sarveshwari Memorial Oration. There is a small story behind it, and as an introduction to this oration, I'm just going to tell you this story. Can I have this on the screen? Good. I remember the 34th this year. So I must have been associated with at least 29 or 30 of these orations, if not a little more. And I started from the audience, then I started helping around with the chairs and decorations of the auditorium. Then I moved up to the vote of thanks, and then introducing the orator, and now introducing the oration. And I think next year I just move out and go back to the audience. Full circle. But that's how time flies. That's how time flies. G. Sarveshwari. Born on 10th June 1947, she was the eldest child to Mrs. and Mr. Rao. He was an electrical engineer from Bangalore, and at that time when they were associated with All India Institute, he was working as an engineer in the copper mines in Korba, or copper plant in Korba, which is in Rajasthan, not very far from Delhi. She studied in Korba and then Bangalore and then in Delhi. And her early schooling in Delhi was in the Andhra School, Delhi. It's a very old and prestigious school near the ITO crossing. Thereafter, she did a BSc Honours in 1968 from Delhi University as a student of a very prestigious girls-only college of Delhi University, the Miranda House. She was an excellent student and she stood first in the Delhi University in MSc Botany and was awarded the Panchanan Maheshwari Memorial Prize for her achievement. A brilliant student. She did a post-graduation, got married and settled down to a happy family life. Between 1968 to 75, she became the proud mother of 3 children. And they were living happily in, I think in Korba. The first symptom of brain disorder was noticed in May 1974 in the form of severe headaches and loss of consciousness. The doctors at Balco at Korba, where her husband was employed, referred her case to AIIMS. Here she was diagnosed to have a malignant astrocytoma. She was operated upon on 12th of March 1976 and a radical tumor removal was done. Professor Tandon, Professor Banerjee, they were my teachers, they were professors here. This was followed by radiotherapy. She made a quick and complete recovery, but the tumor recurred and she succumbed to her illness on 3rd of February 1977. And few months after that, as Professor Tandon tells me, he was called to the director office one day where this lady's father and husband, both of them were there. And they said that she had life insurance and the life insurance has given this money. At that time it was, I think, 1 lakh or 1.5 lakhs or something like that. And the husband and father both said that we want to give this money to AIIMS to start some academic program in neurosurgery. And so the director called Professor Tandon, they discussed, and that's how the Sarveshwari Oration started. And it's been going on for 34 years now. The first oration was done in 1981 by Professor Christian Christiansen of Oslo, Norway. Incidentally, he was also the teacher and professor of Professor P.N. Tandon. He trained in Oslo, Norway, and Dr. Christiansen was his teacher. And over the years, we have some other distinguished orators, starting from the times of Dr. Rasmussen to Dr. Mitchell Berger, who was here in the middle of the COVID. I remember it was all done online, and he delivered the lecture from San Francisco, but it was very well received. And between them, we have had a galaxy of neurosurgical superstars who have presented this oration. Professor Bricolo, Crocard, Dr. Suzuki, Professor Sano, Professor Tetsuo Kano, Dr. Sami. The names are endless. So today we are all gathered here to hear the 34th edition of the Sarveshwari Memorial Oration. And now, may I now invite Professor Suri to introduce the orator. Thank you very much.
Can I have the slides? Respected Director Sir, Dean Sir, Associate Dean, Registrar, Professor Kaleb, Professor Gaikwad, my teachers, seniors. It's an honor to introduce Professor Tanikawa. Can I have the slides? The introduction slides, Priya? Thank you. It's an honor to introduce today's orator, Professor Tanikawa. He's the Executive Vice President and Director of the Department of Neurosurgery and the Stroke Center, Sapporo, Teishinkai Hospital. And he specializes in cerebrovascular surgery, skull-based surgery, vascular reconstructions. This is his institution. He did medical training from the Saikawa Medical College, Saikawa, Japan, followed by the residency in neurosurgery residency under the famous Dr. Yamagama at the Ashikawa Medical College Hospital. And then he was a trained neurosurgeon. And he has been working as the director of neurosurgery at the Abashri Neurosurgical Hospital, followed by the president in the same hospital. And since 2011 till date, he is a clinical professor of the Department of Neurosurgery at the Ashikawa Medical University. He's been the visiting professor at the latest, where it was the last samurai, the famous lecture was taken, was at Phoenix, Arizona, and the Barrows Institute. And the others, he's been a clinical professor, visiting professor at the Tokyo Medical Center, the Fujita Health University, and San Francisco. He has nearly 80 publications, most of them focusing on cerebrovascular surgery, and membership of very revered professional societies in Japan. And he's taken 90 lectures across the globe on cerebrovascular surgery, vascular reconstructions, complex aneurysms, and microanastomosis. And he's been invited to nearly 40 invited surgeries internationally. And he's been a visiting professor with us for the last 3 days, and we've seen wonderful surgeries being performed with our team. On Monday, he did Moya disease with a double barrel STMC bypass on a 1 millimeter diameter bypass. And yesterday, he was operating an aneurysm. Yesterday, he actually nearly taught around 50 delegates in our skills lab in the animal house, and on where he was demonstrating microvascular bypass on chicken wings, arteries, and it was a wonderful display of his techniques. And this is the maestro in action. And he's given these courses all over the world, and he relays them from Sapporo, Japan, and his wonderful team. Professor Tanikawa, we are honored to have you here, sir. You'll have a laptop.
Thank you.
Thank you.
Thank you very much. Here. Oh, it works. So, thank you very much for your invitation, Professor Kare, Vivek. Thank you for your how the organization organizing to invite me. Thank you very much, and all the faculties of AIIMS and Indian Neurosurgery societies. I'm so happy. I'm great. This is a great honor for me to be here. And it's my pleasure to share my experience for this 36 years as a neurosurgeon. Today, I'd like to talk about the principles in neurosurgery. Especially, I always thinking of the important things. As a title here, my main work is exact microsurgical approach to the target lesion, not only aneurysm but also other tumors lesions, and especially in aneurysm surgeries, sometimes vascular reconstructions are necessary. For example, STA, MCA, very popular bypass. Sometimes ACA reconstructions, PCA reconstructions. In the posterior circulations, sometimes we need PICA reconstructions, ICA reconstructions. And according to, by developing the endovascular treatment, especially recently due to flow diverters development, the high flow bypass for internal carotid cavernous segment giant aneurysm is reduced so much. Before flow diverters, I performed the high flow bypass around 10 cases annually, but after flow diverters, it decreased so much, just 1-2 cases nowadays in a year. Anyway, I always talk about this. In a microsurgical approach, this is very important, appropriate exposure, wide enough operative field, and less invasive to the brain. To secure the wide enough operative field, even if you open the operative field widely, without clean operative field, we can't see anything. When I became a neurosurgeon 36 years ago as a resident, unfortunately, my senior neurosurgeons, the operation was so bloody. So during surgery, the operator told us, this is a MCA, this is an internal carotid. In acoustic neurosurgery, this should be a facial nerve, this should be a cochlear nerve in the bloody operative field. And to be honest, I couldn't understand anything, the anatomical structure. Really, is this a MCA? Is this a ICA? Is this a PCOM? I have a doubt during surgery. And the surgical result was not good, to be honest. And at that time, I felt something wrong. This kind of surgery should be improved. When just I became a the resident, I felt like that. And I spent 3 years as a resident in my graduate medical school neurosurgical department. There's sometime I heard about Professor Kamiyama, who was working in Hokkaido University at the time. Everybody says senior neurosurgeon told me, Professor Kamiyama, insanely good neurosurgeon. He must be crazy. Everybody told me like that. But he's so good in surgery. So I haven't seen his surgery at the time. I have no opportunity to see. But fortunately, Professor Kamiyama moved to Asahikawa from Hokkaido University because he had a fight with a professor in Hokkaido University at the time. Because he was too good. That is the main reason why he was kicked out from the university, Department of Neurosurgery of Hokkaido University. Fortunately, he moved to Asahikawa. That was 1992. And 1992, in March, unfortunately, I had the severe hepatitis A. My GOT, GPT increased around 7,000, 8,000. And my senior neurosurgeons believed, Tanikawa must be dead. Because at the time I have a severe excess, severe jaundice, and the GOT, GPT level was terrible. But I fortunately recovered. That was April 1992. And the Professor Kamiyama moved to Asahikawa at the time. Same timing. Now, after recovery, I asked my professor in September 1992, 6 months later after hepatitis A, I wish to go to Professor Kamiyama's hospital and I want to run his surgery. He approved. He allowed me. So that was a game change for me as a neurosurgeon life. And then I have been following his surgical way of thinking, his philosophy. And this is connecting to this philosophy. Clean operative view. His surgery was so clean, so smart, so meticulous. And I was following this way, bloodless operative field. But to say maintain bloodless operative field is easy, but to do is not easy. Everybody already experienced. But this should be the effort as a neurosurgeon during surgery. It's a very important thing. And Professor Kamiyama, he taught me the distal transient approach. This is the fundamental skill for neurosurgeon. This is the very basic skill. For example, this is the actual case, 57-year-old female, small basilar SCA aneurysm. Nowadays, it must be treated the endovascular coiling, but even in this era, we are trying to clip the aneurysm directly, but to clip such a deep-seated distal basilar aneurysm, we need a bloodless, wide enough operative field. This is a distal transradian approach. In this approach, we can only cut arachnoid trabeculae, arachnoid membranes. Do not injure the cerebellum veins. Professor Kamiyama always forced us never coagulate veins, never cut veins. If I injure the veins during approach 30 years ago, he immediately come to me to or change. Then I have to go to the assistant school. Immediately after he changed it, the Sylvian fissure, bloody Sylvian fissure was cleaned up and separated very quickly, very clearly. That was amazing. So I'm following that procedure. Now MCA bifurcation exposed. Now this is the inferior trunk and the anterotemporal artery, which is attaching to the inner surface of the temporal lobe. In order to place the temporal brain spatula on the temporal incus, the anterotemporal artery is elevated, detached from the temporal surface, and now the anterocoroidal artery and uncus adhesion is released, and the decusped membrane posterior to the oculomotor nerve is inside, and the superior cerebral system is opened in the oculomotor tentorial triangle. Medial to the oculomotor nerve, you can see the decusped membrane, the thick decusped membrane there. And now, just below it, you can find the aneurysm, tiny one. But through the complete front temporal separation, if you make the wide corridor in frontal and temporal lobe like this, it's not difficult to see the target. The important thing to do to do exact and safe surgery, most important thing, the visualization of the anatomy of the structure. And like this, even in a deep area, we can add such a complex clipping procedure with a fenestrated clip. We can occlude the remnant of the aneurysm neck, and preserving all the important perforators, especially posterior to the aneurysm, which is coming from the visual bifurcation. It is very important to preserve. And this is a post-operative CT scan immediately after surgery. And CT angio. This was a CT angiography after surgery. Another case. This is an example of a middle fossa exposure as a skull base approach. I usually perform the non-shaving craniotomy with separating hair. This is the relatively larger frontotemporal craniotomy, the larger in the temporal side. And I am doing the temporal base during this here is a orbital skeletonization to expose the meningo-orbital band to inside the supraorbital fissure. That is a foramen rotundum. The V2 is included. That is the foramen spinosum, which is coming the middle meningeal artery. The middle meningeal artery is cauterized and cut. And now the foramen ovale is exposed, but still the dura propria on the V3 of trigeminal now is preserved. At this moment, I'm carefully observing the ovale and the rotundum and the dura propria between the V3 and the V1. The important thing here, that the green triangle is the lateral loop, and the breathing, venous breathing from cavernous sinus partially open, the whole has a breathing. We need a point-by-point hemostasis even in a cavernous dissection, middle fossa dissection. The problem is in a middle fossa dissection, the breathing comes so much. If you detach the dura from a skull base, the oozing from the bone always coming and always disturbed to recognize the anatomical structures. And it is sometimes difficult to see the hiatus of GSPN and to see the dura propria covering a GSPN. But it is said the GSPN must be sharply inside the open, otherwise you may injure the geniculate ganglion and facial nerve palsy. It is always said, but it is difficult to see without the exact hemostasis. But I'm always nervous to visualize such structures without bleeding. So the key is learning hemostatic procedure. Knowledge of hemostasis is very important. Now, we could expose the lesser occipital, lesser petrosal and the great GSPN, greater superficial petrosal, and that is the so-called temporal rhomboid, arcade eminence, GSPN, petrous edge, B3 posterior border. In this case, this is a cholesteatoma. So I am drilling the middle fossa. Everybody knows when we drill the temporal rhomboid, it is safer to begin the drilling from the anteromedial corner along the petrous edge. Then you can gradually extend the drilling laterally toward the GSPN, but we have to be careful. Just below the GSPN, there must be a C6 internal carotid. My mentor, my skull-based mentor, Professor Fukushima, always taught us, do not drill the internal carotid C6. Be careful. Some patient has no bone covering C6 carotid. In my experience, Japanese patients have a thicker bone covering C6 carotid. But in the cadaver head, especially when I performed in US, the Caucasian people's bone is relatively thinner. So that is the reason why he told us be careful. But of course, in Japanese patient, rarely the very thin bone covering C6. This is maybe a difference between the races. This is a anterotemporal approach is one of my favorite approach. This is a modified approach of the Transylvian approach. This drawing is by my colleague Cosmo Noda. If we separate the front and the temporal from this side, we can expose the basal cistern easily. If you elevate the dura propria from the superaortic fissure, we can expose the lateral cavernous sinus structures like this. If we elevate the dura propria like this, this can be an anterotemporal approach, epidural anterotemporal approach. This is a quite useful approach. And we have to understand the important anatomical landmarks like this. Everybody knows in a textbook that we can find it. Important thing is to make the operative field in actual operative field to visualize these structures without red cell. See? This is very important. This video, I have already seen some of you the day before yesterday. Again, I'll show you. This is a basilar aneurysm. And in the lateral view, this aneurysm is just above the apex of a petrous bone. And with this location, we can approach to this aneurysm through the transcerebral anterotemporal approach. But additionally, in this case, to secure the proximal basal proximal to the aneurysm, we need to dissect the tentorium as a transcavernous approach. So I am doing the epidural anterotemporal approach to expose the lateral cavernous wall. And now the dura propria is elevated and the foramen, oculomotor foramen is open, cisternal segment oculomotor, and here is the lyricus membrane posterior to oculomotor. Supracerebral artery is exposed. And now I am dissecting the superior triangle between third and fourth nerve, incising the remaining dura to expose the proximal basal proximal to the aneurysm. You can see the icon aneurysm right there. And the partially the cavernous oculomotor nerve is dissected and mobilized. Then you can make the space to put the temporal clip on the basal proximal. Then in this situation, it is easy to clip the aneurysm in oculomotor tentorial triangle. Of course, tentorial edge is mobilized posteriorly, so this makes easier to approach the aneurysm to secure the basal trunk. Another case. This is a 79-year-old female, very elder patient. Firstly, I told the patient and the patient family, you are so old, so it may be not necessary to clip the aneurysm, but strongly they hoped to undergo surgery. So we try to do the clipping. But the problem is the parent artery, basal artery, is so tortuous and atherosclerotic. So I expected to secure the basal artery quite difficult with the standard approach. So I am doing a combined epidural and a subdural transcerebral anterotemporal approach. I am dissecting the third nerve and the fourth nerve. Here is the fourth nerve dissection in the cavernous sinus. That is the oculomotor foramen. Along the inferior margin of fourth nerve, I am sharply dissecting and releasing the oculomotor, and I'm completely open the trochlear nerve foramen in order to mobilize trochlear nerve and third nerve medially to widen the Parkinson triangle between fourth nerve and the B1. You can see the internal cortex, so severe atherosclerotic change and basal trunk as well. And the cavernous segment oculomotor nerve could be dissected, and some bleeding comes. The fibrin soaked gel foam is put to stop the bleeding. And now the oculomotor is mobilized the longitudinally, very long segment, the trochlear nerve as well. So the Parkinson triangle could be enlarged, but still it's not sufficient to secure the basal, proximal basal. So I am extending the dura just beside the apex of a petrous bone. Then I can make the space to secure the basal trunk. And as I expected, the aneurysm was so adherent to the oculomotor nerve that here must be sharply dissected, otherwise oculomotor nerve cannot be preserved. And much more important thing is the perforators right there, just behind the aneurysm. Those perforators are very complicated if we occlude that. So the highest magnification, brighter operative field, wider operative field to get the much more light from the microscope is very important. So what we did in this surgery is, this is a key step as an anatomy. By opening an oculomotor foramen, opening a trochlear foramen, then third nerve and the fourth nerve could be mobilized medially and extended the Parkinson triangle. And in this operative video, I cut the confirmation of this anatomy, Gruber's ligament, but we could see it. And just anterolaterally, there is a abducens nerve. We could confirm it, which is coming from the inferior petrosal sinus. So even in standard front temporal craniotomy, as a transcavernous approach, we can confirm these structures as a cavernous dissection, transcavernous approach. This is the rarely performed. This is not so often performed, but this knowledge as a skull-based anatomy, the cavernous anatomy, even skull-based, this skull-based anatomy is helpful to approach to crypt the distal basilar aneurysms. The STMCA bypass. This is as well the foods from the MCA large aneurysm. The patient is a 45-year-old woman, the active lady, who is a gynecologist. She has a big concern of the subarachnoid hemorrhage, so she came to me to undergo surgery. Now, my young colleague is doing the double barrel STA M2 bypass. And this is the second STM2 bypass. As I told you yesterday, the everting of a vessel wall is a key to do the successful microanastomosis. Then, after the double barrel bypass, tentatively the aneurysm is trapped, and I'm confirming the filling of the lenticulostriate artery, whether lenticulostriate is arising from aneurysm or not. Fortunately, nothing is arised. So, in this situation, M1 distal and M2, M1 proximal, after resecting aneurysm, it could be attached easily. So I try to do a direct reconstruction of M1, like this. So to maintain the anterograde flow in the M1 segment, it is safer to maintain the flow into lenticulostriate arteries. If we make the stump occlusion, lenticulostriate artery might be occluded as a delayed occlusion, something. This is a high flow bypass for blood blister aneurysm. This patient was Hunt and Cosnick grade 4, almost comatose, who was working in Honolulu in Hawaii. He's a Japanese, but fortunately, when he returned to Tokyo, he had a subarachnoid hemorrhage, and I was asked to operate him. The day after onset, I went to Tokyo and I operated this patient. Now, after making a high flow bypass between the external carotid and the M2 segment using a saphenous vein graft, I am trying to trap the aneurysm. Unfortunately, the PCOM was included in the dissection, dissection of the carotid. This is an anterior choroidal artery. I'm checking the Doppler sound of choroidal artery. This is the low quality of video because this operation was 2008. standard definition video, so not so high quality, but post-operative CT, good feeling of the bypass, and aneurysm is trapped. And this is a pathology, the elastic Parkinson pain. You can see the elastic lamina completely destroyed, multiple parts, and the subadventitial hematoma is right there. So in this situation, the true pathophysiology of the blood-brain aneurysm must be a dissection. This part of the lesion should be trapped with something bypass. I'll show you occipital artery harvesting for occipital artery pica bypass. Something. Anyway. To harvest the occipital artery safely, we need to understand the exact anatomy of suboccipital muscles. This is a surface anatomy, very important. Superior to a supranuclear line, there is the occipital muscle. Inferior to the supranuclear line, sternocleidomastoid muscle inserting, trapezius inserting. Sternocleidomastoid trapezius are the brother muscle as innervated by being innervated by accessory nerves. Just below sternocleidomastoid, there must be splenius captus, which is originating from a C3, T6 spinous process for the mastoid body supranuclear line. Medially, there is a semispinal just below splenius. These two muscles are superficial muscle, sternocleidomastoid trapezius as well. Superficial muscles has a long distance between origin and the insertion. So these big muscles, superficial rotating big muscles, should be preserved when we operate. The cutting at muscular belly always causes muscular atrophy and the dysfunction of the head supporting, neck support. After incising the skin and elevating skin flap, you can expose these structures, and the sternocleidomastoid can be detached from supranuclear line. Like this. Then you can expose the subcutaneous occipital artery. This segment, this exposure is quite important. And after elevating splenius captus, you can find the intermuscular artery, but this is very important. Like this. By muscles, but we have to realize that always asterion is covered by occipital muscle. Without elevating, detaching occipital muscle from the bony surface, you can't expose the asterion. And occipital muscle is connecting to a aponeurosis, and the Gary aponeurosis is connecting to a frontal muscle as a tendon of both muscles. So the occipital muscle, occipital artery, subcutaneous part of occipital artery, in this part, occipital artery is running just above occipital muscle, and then in the distal part, the occipital muscle disappearing to the Gary aponeurosis, transitioning, Then these peripheral arteries, STA as well, these peripheral arteries is running above carrier, below subcutaneous tissue, adipose tissue. So this is the principle of anatomy, the easy anatomy. And then you can detach the longissimus capitis. Before detaching it, longissimus capitis is attaching to the inferior half of mastoid body. If you elevate this, usually you can expose the occipital artery. But in this slide, occipital artery is located medial to a longissimus capsule, inferior to a longissimus. This is a 70% grossly. The 30% of patients have the occipital artery running lateral to a longissimus, outer. Number is 33.6%, around 200 cases of occipital artery analysis in our hospital. And 66.4% was medial course. And the important thing, in the outer course of occipital artery, lateral to a longissimus, when we are elevating splenius capitis, you may injure the occipital artery just above the longissimus capitis. This is something pitfall when we are dissecting occipital artery, so we have to be careful. I have several experience to injure the occipital artery here, and I had to do an end-to-end anastomosis with crying before craniotomy, during muscular dissection. I was crying with a 9-0 suture, make the end-to-end anastomosis. And after elevating longissimus capitis, here you can find the superior oblique muscle. Still semispinalis is attaching to a supernucleus. With this situation, occipital artery, the harvested area can be mobilized outside like this. I do like this. Then semispinalis detached from a supernucleus. Then you can expose the so-called third layer occipital muscle, superior oblique, rectus capitis, posterior major, and minor. And the inferior oblique muscle is hidden, still hidden. But the superior border of inferior oblique, medial border of rectus capitis, posterior major, posterior border of superior oblique, this triangle is so-called suboccipital triangle, which is including the vertebral venous plexus, which is surrounding the vertebral artery, V3 segment. This is a very important anatomy. Then, the superior oblique muscle is most superficial in this structure. So, superior oblique muscle can be detached from inferior nuchal line. Then you can open the lateral edge of a suboccipital triangle. Then rectus capitis, posterior major and minor can be detached and deflected inferiorly. Then you can expose the inferior nuchal line as well as the supernuchal line already exposed. The bony surface could be exposed like this. Then if you open the vertebral venous plexus, of course, after removal of the fat part here, you can expose the vertebral artery. With this condition, we can transparently expect the lining course of a transverse sinus and the TS junction sigmoid sinus. Here should be the mastoid emissary vein, mastoid emissary canal. Here is the sigmoid sinus hip. And in the depths, in a suboccipital triangle, there is a vertebral venous plexus surrounding a vertebral V3. And vertebral venous plexus and the jugular bulb is connected with the so-called posterior condylar emissary vein, which is coming into a posterior condylar emissary canal. To expose the condylar fossa here, we need to expose the posterior condylar emissary vein and coagulate it and cut. Then you can approach to a condylar fossa. Here is the occipital condyle, C1 condyle. So in this situation, we can perform the suboccipital craniotomy like this, expose the foramen magnum, then you can expose the marginal sinus. Part of marginal sinus has a draining between vertebral venous plexus. Vertebral venous plexus has already sacrificed to expose the V3 segment in this picture. After drilling the sigmoid sinus hip and the condylar fossa, you can skeletonize hypoglossal canal right here, just above the condylar facet. Condylar facet here, hypoglossal canal here. The angle between the condylar facet and the hypoglossal canal is approximately 15 to 20 degrees always, bit upward running of a hypoglossal canal. This is a very important anatomical structure feature. And this remaining bone just above a hypoglossal canal is a part of jugular tubercle, almost a posterior half of jugular tubercle. You can drill here to reduce the protrusion of jugular tubercle in the subdural space if you necessary. So this is a very important anatomy in suboccipital craniotomy with transcondylar fossa approach and with harvesting occipital artery. In my experience, without layer by layer suboccipital muscular dissection, regardless you harvest occipital artery or not, the unblocked retraction of suboccipital muscles with something, the sigmoid-shaped incision here, these muscles always bulky and makes the operative field deep. Like operative field is here, and you operate from here like this. But layer by layer dissection, each muscle reflected in different direction, and it makes operative field shallow. This is a big advantage of a layer by layer dissection. This is a 59-year-old man, bilateral fusiform vertebral artery aneurysm, including pica. This is the left side. Now, along the supranuclear line, skin is incised. The subcutaneous occipital artery just above occipital muscle is exposed, occipital vein. And the subcutaneous occipital artery is harvested. And then vertically, the skin incision is extended. The carefully exposing the sternocleidomastoid tendon. Here is the perioauricular posterior, which is connecting to ear cartilage. And the subcutaneous occipital artery is coming, connecting to the intermuscular occipital artery, just below the splenius capitis. Here is the posterior border of sternocleidomastoid. Here is the supranuclear line. Occipital muscle is right here. So I am detaching occipital muscle, and here is a sternocleidomastoid attachment to the supranuclear line. Here is splenius capitis attachment here. Here is the superior border splenius. That is the mastoid tip. Inferior corner of splenius capitis is detached from mastoid tip. Now here is the longissimus capitis attaching to the inferior half of a mastoid body. The occipital artery in the intermuscular layer is harvested. Now, occipital artery is running medial to a longissimus capitis. Semispinalis as well. detached from supranuclear line. Here is the superior oblique detached from inferior nuclear line. Now, here is the adipose tissue. The rectus capitis posterior major is detached from inferior nuclear line. Now, partially the vertebral artery and the venous plexus is exposed here. These are the venous channel of a vertebral venous plexus. C1 lamina is right there. Here is the asterion, rhamnoid, parietal muscle. Then you can make the suboccipital. I am doing the condylar fossa to skeletonize hypoglossal canal. Condylar fossa is here. Hypoglossal canal is here. And this is the remaining jugular tubercle just above hypoglossal canal. Hip of sigmoid sinus is right here. Then you can open the dura just above the foramen magnum. The 9-10, the jugular foramen, and the pica is right here, just inferior to a tonsil, just above the medulla oblongata. And a pica is vascularized with the occipital artery. In order to trap the aneurysm, accessory nerve, jugular foramen, 9, 10. Here is the aneurysm. Here is the hypoglossal nerve toward the hypoglossal canal. The reconstructed pica is resected from aneurysm, already trapped the aneurysm. Now, I am resecting the distal end of the aneurysm, and here is the proximal end of aneurysm. Just below the aneurysm, you can find the contralateral vertebral artery. Fortunately, in this case, the distal intracranial vertebral artery could be dragged out to the 9 and 10 complex, and this is the harvested radial artery graft. I am doing end-to-end anastomosis with radial artery, intracranial vertebral artery, in order to reconstruct the vertebral artery. The proximal end of radial artery is anastomosed to extracranial V3 segment of vertebral artery. Then opened it. The left vertebral artery is reconstructed because this patient have the contralateral the fusiform aneurysm as well. So in order to, in case of the other side growing up, if I did the simple trapping in left side, the other side cannot be simply occluded. So to avoid such a situation, I reconstructed the vertebral artery with the radial artery. So this is a summary. To understanding anatomy, by understanding anatomy exactly, and go to cadaver lab and doing the dissection, not only bony drawing, dissection of soft tissue, muscular tissue, the neural tissue, everything, then gradually we can achieve the knowledge. The skill is always based on the knowledge. So before achieving the skill, we need to learn the knowledge of anatomy. Then naturally we can achieve the skill to do the surgery safely. You see, it's very important. So we need to learn these anatomy. It takes time. More than 20 years. I began the skull-base anatomy learning in 2000 when I was 38. I have been learning skull-base around 24 years, in this 24 years. But still, I have a lot of the unclear anatomy for me. So still, I am learning the skull-base anatomy, and I want to go to a cadaver lab dissection every year, every month, but it's impossible. I force young guys to go to a cadaver dissection. Instead of this, I can't go to the cadaver dissection. But it's important for young guys to cover, to treat the future patients, to educate young guys, continuous education for young guys. This workshop as well. This workshop educating people, young people, of course, the senior people, continuously learning as a life work. It's very important. Thank you very much.
Thank you, Professor Tanikawa, for that excellent presentation. I now request Professor M. Srinivas, the director of our institute, and Professor K.K. Verma, the dean academic of our institute, to present a memento to Professor Tanikawa. Now I request Dr. Sweta Kedia to propose the vote of thanks.
Very good morning to all of you. As Dr. Kale had put up, there is always a hierarchy ladder we climb up. Since Professor Sharat Chandra is not here, I was privileged to get the opportunity to propose a vote of thanks on behalf of Department of Neurosurgery, All India Institute, Medical Sciences, Delhi. I extend my thanks to the Sarveshwari family. I think this is the 34th oration that we have just witnessed, and it has been great and it's been improving every year. I also extend my gratitude to the director, sir, dean academic, sir, associate dean, sir, registrar, sir, to find time and be seated here and grace us and the audience with their presence. Also, my senior faculties and mentors, Professor B.S. Sharma, sir, Dr. V.S. Mehta, Dr. Rest of the senior colleagues who are available here. I also take this opportunity now to welcome you all for a short tea break before we begin with our case discussions. Thank you.
Hey, check, check, check. Hello. Hey, check, check. Manjeet. Hello. Manjeet.
यस
हेलो।
यस यस हाँ शिवा बोलो।
हाँ मंजीत।
हाँ मंजीत अभी ओटी में है, हाँ बताओ।
ठीक है ठीक है।